Hello and welcome. My name is Dr. Jack West. I'm a Seattle-based medical oncologist and also the founder and CEO of GRACE, the global resource for advancing cancer education. GRACE has partnered with the Longevity Foundation to bring you a webinar today on immunotherapy for lung cancer. Can we deliver on the promise? And to answer that question, I'm very pleased to welcome two renowned colleagues who are also good friends of mine over more than a decade of working together in this field. And they'll be splitting the promising lines on this big topic. The first speaking today will be Dr. Ramaswamy Govindan, who is the co-director of the section of medical oncology and a professor of medicine in the Division of Oncology at Washington University School of Medicine in St. Louis, Missouri. We'll then have Dr. Julie Bramer, lung cancer expert and associate professor at the Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland. So with that, let me turn it over to Dr. Govindan, and he'll be covering the MAGE-A3 vaccine and Stimuvax, as well as Lucanix.
Thank you very much, Jack, and good evening, everybody. What I wanted to do today is just to give an overview on why immune system is important in cancer and what we can do about this. Jack said we're going to split this, and I'll be focusing on three different approaches. Again, these are not currently available drugs, so I just want to put this in perspective. These are ongoing clinical trials, and many of you may have heard of these trials, so it just will help you understand why we do this and what we expect out of that. And Dr. Bramer will cover the other aspects of immune therapy for lung cancer. So I do not have any conflicts as I'm discussing this. I do want to acknowledge the help I've received from the study teams for those different agents. They've given me slides over the last few years. I'm using those slides sporadically here and there. I just want to bring up one important point, that what is the link between cancer and immune system? Many of my patients have brought up this issue. I just want to boost my immune system, and therefore I'm taking these supplements. Immune system is a beautiful system that is essentially here for one reason, to prevent foreign agents or foreign proteins attacking our body. So for that to identify something as foreign, it has to know self. So early on in our life, the immune system learns very well to recognize the self from the foreign and avoid killing self tissues, avoiding killing own tissues, and go after the foreign substances, whether it is a bacteria, virus, or a foreign tissue, as would happen with the transplantation if they are not matched properly to the host. And in that process, cancer comes in. Why does cancer come in? Cancer comes in because as the cells become malignant, they also actually have a lot of different proteins on the cell surface. After all, every cancer cell at one point began from a cell that used to be a normal cell, and the normal cell becomes cancer cell. The proteins or the genes get modified, and some of them are expressed on the cell surface, and that are very different than what the immune system used to. And therefore, the immune system has the capability to identify those non-self, even though it arises from the self tissue. But somewhere along the line, the immune system gives up on this, and the cancer cells continue to grow unabated. But we know one thing, that the immune system is important, and there are several lines of evidence that suggest that the immune system plays a role, at least at some point. First and foremost, when we look at the tumor tissue, we can actually find tumor cells infiltrated with lymphocytes. Lymphocytes are the white cells that actually are involved in the immune process, the immunity, to a great extent. And there have been instances of spontaneous regression of tumors. And in my 15 years of oncology career, I've had a patient where the tumor spontaneously regressed. And there have also been instances of tumors regressing after a primary tumor is resected. This has been reported more often than seen by most of us, and this happens far more commonly, if it happens at all, in kidney cancer in particular, where the metastatic lesions disappear after removing the primary tumor. Clearly, there is an increased incidence of cancer in patients with weakened immune system, either because of immune deficiency, most commonly is the acquired immune deficiency syndrome or AIDS, where the few cancers are very common in this population. And sometimes we weaken the immune system deliberately to tolerate transplanted tissues, and we suppress the immune system, and those patients are also at a high risk for certain cancers. Curiously, these patients are uniquely susceptible to certain cancers, like cancers of the lymphatic tissues, the lymphoma, skin cancers, and a few other cancers. Not every cancer is increased in this. So the take-home message from this part is that the immune system plays an important role in doing the surveillance among the tissues to prevent a cancer cell from emerging, and does, for most parts, a reasonably good job. But somewhere along the line, it just drops its guard, and we are trying to understand why that happens, how that happens, so that we can actually use that to selectively boost some parts of the immune system in a very logical way before we approach this in a systematic fashion. So clearly there's a compelling need for studying this. The second point I want to make is there is a process called immune editing, and I would not bore you with all the details. If you can see on this slide, the normal cell becomes cancer cell over a period of time, and that often happens because the genes get mutated or altered, and it's a bit of a random process. Any gene can get mutated, and over time, if it's key portions of the cellular genome, a normal cell could turn cancer cell over a period of years often, and rarely over a short period of time. During this process, the immune system tries to recognize these things, these cells, and tries to eliminate this to the extent possible. But somewhere along the line, as I said before, either the immune system drops its guard or the cancer cells mutate and evolve to avoid the immune system, and then they reach a point where they learn to tolerate each other. Eventually, the cancer cells don't really care, the immune system does not really care, and then the cancer cells grow quite significantly. During this process, we identify a lot of different targets we can go after. Again, I would not go into the technical specificities, and Dr. Bramer will talk specifically about the PD-1. There are some different proteins that we can go after that can help improve the immune process, the way we can actually weed out these cancer cells. So that's in a nutshell the key point, that the immune system is certainly a legitimate target for us to go after. I will focus the next 15 minutes or so on three different aspects. One is a protein called MAGE. This is a trial called MAGE-A3 trial. This MAGE protein is present in about a third of patients with non-small cell lung cancer. The MAGE vaccine works in this way, and this is a cartoon. You shouldn't trouble yourself with the details, but the bottom line is this protein is put in something called plasmid and produced in microorganisms, purified, formulated. And as always with immune therapy, they are actually boosted with what we call the adjuvant system to make the immune therapy work better. This is called the antigen-specific immune therapy, or ASCII. The way it works is that once you inject this, often into the skin, this will provoke the immune cells, the T cells in the body, to come together, and they actually, working in cooperation with other cells that produce some antibodies, create some specific cells that will go after the tumor cells to kill them. So it's a finely orchestrated process. Immune system is not a very simple thing. It's a very complicated process. Different cells interact together. They often work in cooperation to make this happen. And it's a very neat theory behind the idea of why the MAGE-A3 vaccine would work. The idea is that in a third of the patients with non-small cell lung cancer, when the MAGE-A3 protein is on the cell surface, we can actually provoke an immune system by creating specific vaccine towards them. And it's a very easy test to do, and it's actually fairly well standardized. And the MAGE study for the early stage non-small cell lung cancer, and all the three that I'm going to talk about will focus mostly on the early stage. Here you can see that the main group of patients for this study are those who had a complete resection and whose tumor has been found to have this MAGE-A3 protein on the cell surface. And by the way, this is the direction cancer therapy is moving towards, not to treat all patients with lung cancer in the same fashion. Identify patients based on what's on the cell surface, what genes are altered, and that's the way we are developing these days, as you know well, targeted therapy. And the same, I believe, is going to be true for immune therapy as well. And when you give this to these patients, quite often you find small skin reaction, but by and large, these vaccine therapies, across the board, they're very well tolerated, and the side effects are very, very minimal. And the challenge for us is to identify patients who are likely to benefit. A place to start is to select patients through this MAGE-A3, but it turns out we can probably do some more sophisticated thing, looking at a bunch of genes in the tumor cells to identify who may benefit, who may not benefit, and that work is currently ongoing, and we may be able to define better who will benefit, who will not benefit. The MAGE-A3 vaccine approach is being tested in other cancers as well. An example here is this kind of gene signature where we look at a number of genes across the board in a group of patients who respond, who don't respond, and develop these predictive signatures or biomarkers. It turns out that there are a group of patients here who do well compared to the group of patients who do not do well. These are very early studies, not enough for us to say that this is the way we should select patients. The early studies suggest that it is possible to select patients who would benefit mostly for the MAGE-A3 vaccine in a two-tier approach, if you will. The first tier is to use the MAGE-A3 protein on the cell surface. That's the entry point. If you don't have the MAGE-A3, it doesn't even make any sense to try. And even if you have the MAGE-A3 on your cell surface, not everybody will probably benefit. It's possible that looking at the tumor, grind the tumor, and then get the DNA out of that and make RNA, and then look at some of the expression levels and identify a set of patients who would benefit more than who would not benefit. Again, this has been tested in melanoma. There are some indications that this may be true for lung cancer. But in my opinion, it's too early to say that this is the way we would be selecting patients. The same signature pattern in a preliminary study with this, as I was telling you, shows that you can identify two groups of patients, those who benefit, those who don't benefit from the MAGE-A3 vaccine. This study is almost done and will take a few years before we will know the full extent of this. But this is the future where we are trying to identify subgroups of patients in a same disease and use either targeted therapy or immune therapy. The MAGE-A3 trial, the MAGE-A3 trial, will be one of the largest trials ever done in non-small cell lung cancer, and we are hoping that it will show some benefit based on that. Switching gears, going on to the second part of this, the Stimuvax, again, a similar approach, but slightly different protein. By the way, we have 20,000 genes in our cells, and it turns out that over a period of time, a few hundred to perhaps even sometimes several hundred genes get altered. Of course, most of them are probably not that important. A handful of them are important genes that once they get affected, a cell can become a cancer cell. Consequently, some of those changes would result in alteration in the expression of proteins on the cell surface. And MUC1 is another protein that actually is altered in some of the cancers. And the idea is we can use that altered protein to trigger the immune response. And again, like before, you have a protein. There was a MAGE-A3. Here is a different protein called the MUC1, and then you have different components to create the vaccine. Some of the early studies have shown some promising results, and this is a study that was published about 7 years ago. A group of patients with advanced lung cancer, once they got chemotherapy, after they've done reasonably well, the patients got this vaccine or best supportive care. As you can see, it's a fairly small study, and you can see that there was a difference in the outcomes. If you look at the patients with stage 3 and B, you can see there was a group of patients who got therapy. The survival was about 17 months, median average survival compared to 13 months. And I'm sure many of you are used to looking at these curves, and it's better to be on this side than on this side. This is with therapy. That is, those who got chemotherapy and the vaccine compared to just chemotherapy alone. But if you take a group of patients who have actually a slightly earlier stage of cancer, what we call stage 3B, the difference becomes even more striking, as you can see here, almost about 2.5-fold increase. We look at more on the hazard ratio and the p-value to identify whether these are by chance or whether there could really be some truth to this. And these numbers are quite promising. That really led to more advanced studies and the different variations, how you can give it. A few cycles, a few doses of chemotherapy actually helps the vaccine work better. And this is the second study then again showing some promising results, similar to what I just showed you a minute ago. That led to this larger study that is currently ongoing called the START study, where patients with unresectable stage 3 lung cancer who got chemotherapy and radiation then get randomized to the vaccine or best supportive care. Remember, the MAGE-A3 study or the MAGE-A3 was focusing mostly on patients, so all patients had surgical resection. Here, it's a different group, slightly more advanced group. That's a stage 3 group who have had chemotherapy and radiation. You may recall that I just showed you a few minutes ago that the best benefit was seen in the stage 3 rather than in the stage 4 group, and that's why the START study is focusing on stage 3 population. Again, we will have some results in about a couple of years. Finally, the Lucanix study. A lot of tumors secrete a protein called TGF-beta. TGF-beta actually helps the immune system to go to sleep, literally, to use a very simple term. When you have the tumor cell secretes the TGF-beta, what happens? The normal immune system that are actually guarding against the emergence of these bad cells literally stop working in a way, and there are some compelling scientific studies to support the idea. The Lucanix vaccine is essentially using this concept. What happens here is that use the cell lines that are with genes modified to block the secretion of the TGF-beta secretion and then thereby prime the immune system to react against the cancer cells. This approach has shown some promising results. You can see here in a group of patients who have actually, before vaccination, after vaccination, you can see that in a patient with glioma, for example, you can see a lot of these activated T cells. And after giving this Lucanix vaccine, what happens is that once you give this vaccine that actually helps the T cells get activated, they infiltrate the tumor cells, and hopefully that will result in better activity. Here, in a very small study, patients actually were assigned to 3 different doses, and they were given monthly intradermal injections. It's very easy to get, and you can see that the survival in a group of advanced disease patients look actually better, especially with the higher doses. You can see that numbers look very good compared to what we normally see. And again, these are very preliminary data, so it's important to keep that in mind. And if you look at a group of patients who have actually responded reasonably well to prior chemotherapy, again, by the way, these vaccine therapies themselves are not likely to work in advanced disease. They may be good maintenance therapy after chemotherapy in the advanced disease, or good maintenance therapy after chemo radiation in stage 3 or after surgery. So you have to do some primary therapy to debulk the tumor or control this, and then use this to prod the immune system to work better against the remaining cells or to control them. And you can see that those who did actually better on chemotherapy benefited from the vaccine than those who didn't. And again, these numbers are eye-popping numbers. With 44-month median survival, we are typically used to about 9 and 10 months. Clearly, these results look promising enough to be explored. Again, many times you can find some early reactions, early benefit that are very promising, but unless we follow up and confirm that, sometimes we can be misled based on patient selection and a few odd responses here and there. Only large studies can definitely tell us whether these are real, and those studies are currently ongoing. This slide should tell you about in a sense, this captures the side effects of immune therapy compared to chemotherapy. This was put together by the Lucanix group, and as you can see here, compared to chemotherapy of different types, I'm sure all of you are familiar with these chemotherapy drugs, Taxotere or docetaxel, pemetrexed. Of course, Avastin is not chemotherapy. It's bevacizumab that inhibits VEGF, a protein that is important for tumor vascular angiogenesis. And Tarceva is a drug that turns off a different protein called EGFR. And if you look at the side effects, you can see here severe side effects, particularly low blood counts, are literally 0 here. Treatment-related deaths are again 0. Very few patients discontinue with vaccine therapy in general. Here you can see nobody got hospitalized because of vaccine therapy. This story is not new, and vaccine therapy is well tolerated. As it's been pointed out here, it's like getting a flu shot once a month. So clearly there is a great appeal here because how well it's tolerated. So the phase 3 study will be focusing on stage 3 and stage 4 patients who had some chemotherapy, and then will be randomized to get chemotherapy or no chemotherapy. And hopefully in the next few years you will know more about these things as we come along. The update actually as of a month and a half ago, the goal is to accrue about 500 patients, and we are almost there, 420 patients. It will take again a few years before we know more whether these things are going to work or not. So in summary, before I turn this over to Dr. Bramer, is that there is a lot of promise with regard to immune therapy. As always, we need to do more scientific work. Many of us were very skeptical of immune therapy until a few years ago, but I would argue that today there is a lot of interest in immune therapy on the 3 agents I talked about, following chemotherapy, chemoradiation, or following surgery. These 3 different approaches will be used. And Dr. Bramer will talk about specifically some of this immune therapy. There's also a new approach that's emerging where we are trying to learn how to identify all the altered genes in cancer cells and figure out which one of them is more immunogenic and develop vaccine therapy based on which protein is more likely to be useful for personalized vaccine therapy. So I really think the vaccine therapy is going to really get a second life in a big way, and I'm hopeful that this will help our patients in the coming years.
We'll continue with Dr. Julie Bramer's discussion of additional immunotherapy strategies in the next podcast. Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.